welcome to the Might Ramble podcast.
Ron, tell us about that.
Not 2, not 3, not 4, not 5.
Now I am become death, the destroyer of worlds.
From this distant vantage point, the Earth might not seem of any particular interest.
Hello, everyone. Before we begin, the views expressed in this podcast are our personal views and do not reflect those of any employer, university, research institution, funding body, or collaborator. Participation by guests does not imply endorsement of my views, nor does my hosting imply endorsement of theirs. Okay, that's all. Hello, everyone. Welcome to episode 17 of the Might Ramble podcast. Today, my guest is Lorenzo, I think, Leggio.
We said Leggio, but
Leggio.
It's totally fine.
And I've flown out to Baltimore here to come and speak with him today about addiction and his career. And there's a lot of discussion in terms of treatments for addiction currently going on. It's definitely an evolving landscape. But Lorenzo, thank you so much for your time today. Super appreciative of it. I was wondering if you could just give us a little bit of a, background or CV of sorts of how you ended up doing what you're doing now and what are you doing now?
Sure. Well, first of all, thank you so much for having me, and thanks for flying from Texas to a rainy day here in Baltimore. As you say, my name is Lorenzo Leggio. I always tell people my accent is not from Baltimore. I'm from Italy. I actually grew up in Sicily, in a very warm, small town in the south of Sicily. And really, my family has a dairy farm, so they have cows and a bunch of other farm-related agriculture stuff. So there were no physicians around in my family, even my extended family, including uncles, aunts, etc. But then I was very passionate about science and reading a lot, etc. I was debating whether going to a degree in science. But then basically, my grandfather died with stomach cancer. My dad, who is still alive, is 91. Wow. He had colon cancer at that time. At that time, in particular in the south of Italy, colon cancer was really death on arrival. So that was really a turning point to me to think about not just a passion for science, but more about medicine and helping people when you are confronting a situation like one of the loved people in your life who may die. So I decided to go to medical school, and during medical school, so I did go to medical school with the idea of becoming an oncologist. But of course, that didn't happen. And as often happens to medical students, you change your plan as you start studying. And for me, what happened by studying biochemistry in particular, I was very interested in how the liver in particular does process pretty much everything in our body, being this sort of a biochemistry hub in the body. So I decided to go to internal medicine. And while I was a medical student, I also resurrected my passion for science. So I started to do some research as part of my rotations during medical school. And then what happened, I enrolled to a research track residency in internal medicine, and then I also pursued a PhD in the same department of internal medicine. And between my residency, which was a 5-year in internal medicine, and my PhD, I would say 3 things happened. One, I was very lucky to have the mentoring of a physician scientist who was in the internal medicine department, but he was actually building an alcohol treatment unit in that department. So very unusual, at least at that time. The second thing was that why I continued, and I still continue to have interest clinically, scientifically on hepatology, which is liver, I also became more and more interested in the addiction side of biomedical science, both clinically treating people with addiction and research-wise doing research in people with addiction, primarily alcohol use disorder.
And what about, just to interrupt you a little bit,
please.
But what about addiction, I guess, was interesting or incredibly interesting to you in comparison to other things, that you could have pursued? Why addiction?
Yeah, I think it really, the motivation was really clinically driven. So at that time, so nowadays, for example, we have a vaccine for hepatitis B. We also have a very effective treatments for HCV, Hep C. At that time, there was nothing. I mean, there were some treatments for HCV, for example, but they were very non-specific. But at least as a medical student and then resident, there was a lot of focus on developing treatments, medications for this liver disease, hepatitis, B or C.
And hepatitis is a common result of alcoholism, right?
Correct.
Yeah.
And also opioid use disorder.
Yep.
So I was puzzled that in a way we were focusing so much, for example, on the treating HCV, but no work, for example, on preventing the transmission of HCV, which is strictly related to opioid use disorder.
Yeah.
But then the other elephant in the room was that I was seeing thousands of patients with alcohol-related liver disease, up to people with alcohol-related cirrhosis and people going to liver transplantation. And there was still a lot of focus on the liver, but there was not really a lot of focus on the underlying problem. So people with alcohol liver disease, they don't have a liver problem. They have a liver problem as a consequence of addiction.
Yep. And I misspoke earlier. So
Please.
cirrhosis is a common result of alcoholism, not necessarily hepatitis, right?
Correct.
Yeah. That was my bad.
Both.
Yeah.
I was part of my mentor of this liver transplant team, and we were in charge of vetting and approving people to go to liver transplantation if they had an alcohol use disorder history, etc. And again, I was very puzzled by the stigma around, where the surgeons were totally okay to do the liver transplantation for a patient with hepatitis, but they were pushing back on people with, I will quote, alcohol addicts, using a stigmatizing word. So that really led me to become more and more interested as a physician and someone who wants to be a physician scientist on addiction. Like why we are not paying attention to the underlying problem. These are not bad people. These are not people who chose to damage their liver. These are people who have a medical problem, a medical disease called alcohol addiction, and one of the consequences of alcohol addiction is liver failure. So that kind of was, for me, a turning point to really switch more and more, not only my clinical work, but even more important, my research interest in addiction.
Yeah.
And at the time, in discussion with my mentor, I was able to receive some funding from Italy to do a visiting scholarship outside Italy, and it happened to be here in the States, Brown University in Providence, in Rhode Island.
I know Brown. Yeah.
And you know Brown too.
I've spent a little time there for
Yeah.
sure, up on the Brown Hill. So
Yeah, well, actually, I meant to ask you, what years were you at Brown?
I was at Brown 2023 and 2024.
Okay, so we
Yeah.
definitely we did not overlap. I was there 2007 to 2012.
Yeah, unless you visited, because I
Yeah.
know you have an adjunct
Yeah.
appointment there.
Actually, I come at least once a year to Brown to see my friends and colleagues, etc.
And actually, it might be good if you like list out. I think you have like an appointment at Georgetown and Johns Hopkins and Brown, and then like what your formal title is.
Right. So right now, here at the NIH, this is my employer, the National Institute of Health, which is part of HHS, so part of the executive branch. So I have actually multiple roles. So I'm a physician scientist. I have my own laboratory. But when we say laboratory at the NIH, we mean basic science laboratory and or clinical laboratory. So I'm what we say PI, principal investigator.
Yep.
And as a principal investigator, I lead a team of staff and trainees who do clinical research in people with alcohol addiction.
Yeah.
And we also do some big data analysis. We also do some preclinical work in collaboration with other scientists. One example is my dear colleague and collaborator and friend Leandro Vendruscolo, who's here at the NIH. So we do a lot of work in mouse and rat models of excessive alcohol drinking or fentanyl administration. Yeah. And the work we do with mice and rats is really complementary to the human work we do with patients.
And is there typically like an intermediate stage there, like where you would go up to other primates, say?
Some people do. Our approach is primarily in the rodent models, so
Yeah.
rats and mice, and in the humans with healthy controls and primarily patients with alcohol addiction, and then the big data looking at the electronic health records. using an approach which we call pharmacoepidemiology, which seems like a buzzword. Maybe it is a buzzword.
A lot of syllables.
But basically, it's taking advantage of electronic health records to actually speed up medication development. So that's my job as a principal investigator. I also lead a branch, which is called the Translation Addiction Medicine branch, which is part of the clinical program. And as a branch chief, my role is to oversee the entire branch, which includes my own lab as a PI and 2 more labs from 2 independent scientists who are Brenda Curtis and David Epstein. And I'm also the clinical director, so I oversee the entire clinical program, which includes my own branch, but 3 more clinical scientists, Thorsten Kant, Amy James, and Yong Yang. And I'm also the deputy scientific director, so in that role, I work closely with the scientific director, Amy Newman. And so Dr. Newman and I work closely to lead the intramural program. And my role, she's in charge of the entire intramural program of NIDA, the National Institute of Drug Abuse. And my role is to focus primarily in leading the clinical component.
Yeah. It's interesting. I don't know if you've ever seen Game of Thrones, where it's like Daenerys Targaryen, first for her name, title. And this is what I'm thinking of right now as you list these out. But coming back to, kind of your roots as an addiction scientist, as you were seeing in, treating patients with, it sounds like primarily alcohol use disorder at that time, was there like an emotional component in the sense of like you were interested in why is this stigmatized? Because I believe it's a disease, right? But like, was there a human part of that of like, something's wrong about this and I want to try and make a difference?
Yeah. Oh, absolutely. I think, like I said before, my interest in working on addiction was really driven by my personal investment as a physician to help these people. I was very conflicted by the fact that my patients with alcohol addiction were treated much different in the same hospital, in the same department, compared to people with other disease. And to me, it was clear that no matter what was the reason why they had liver problems or cardiovascular problems, no matter what the reason was to need a liver transplantation or whatever else, they were all patients. They were all good people seeking help. So that sort of stigma around was definitely a big factor for me to try to basically play a role and contribute to a solution and not just identifying the problem. And there were also some tangible components, meaning that, so I grew up not as a psychiatrist. My research fellowship at Brown was in psychiatry, but my clinical training was in internal medicine. So at the end of the day, these people had medical consequences, liver failure, hypertension, cardiomyopathy, and many more examples, pancreatitis. I could go on and on with examples. So that in its own speaks about the fact that this is a medical problem because it has all the constellation of a consequence, not very different than diabetes. So you have a diabetes, and as a consequence of diabetes, many people develop this consequence of diabetes, kidney failure, cardiac failure, retinopathy, etc., etc. Alcohol acts in a very similar way, the difference being that with diabetes, that sort of a trigger is having too high glucose levels in your blood, sugar. With alcohol is too high levels of alcohol in your body. But there are actually many analogies. Actually, we have published a lot about the not with diabetes, but primarily about obesity, about the analogies and the similarities between the obesity phenotype and the addiction, including alcohol addiction phenotype.
Yeah, and I think later on in this conversation, we're going to get more into like GLP-1s and their potential application to addiction. But I think that I saw maybe you had made a public comment about the idea of people that are obese, they struggle, probably struggle with a lot of what we would call food noise, right? Where it's kind of this cloud in a way that hangs over you, right? And addiction-wise, I think you had mentioned something about, like substance noise, right? Which I would refer to as an addict myself. And there are varying degrees of severity in terms of experiencing this, but it's craving of sorts, right? Where you're kind of, in some sense, it's always there and a little bit bothered.
Correct.
Coming back to your kind of addiction roots, so to speak, was there ever a time before your scientific or medical training where you didn't view addiction as a disease? And maybe it was just something you hadn't thought that much about prior to your training. But
Right. Oh, I would say absolutely. I mean, I grew up in a relatively small town. I mean, 50,000 people in the south of Italy, where, for example, drinking wine was very normal. On the other side, people with addiction problem, I didn't have actually nobody close in my family that I knew, but remember just rumors about that person he's an addict, that person is an alcoholic, all these stigmatizing words. They were part of my culture. They were not bothering me at the time because I just didn't know what I didn't know. So in a way, yeah, I mean, I was part of a society where addiction was stigmatized, and I didn't realize that in fact it was stigmatized. So for me, kind of the eureka where I started to realize that was during medical school. Even within medical school, I don't think that's something I realized right away. You know, you go to medical school, the first part, in Italy, medical school is 6 years rather than 4 years. But for the first 2-3 years, you primarily do, you know, the basic like biology, anatomy, biochemistry, physiology, pathology, etc. And I don't think at the time even I fully realized the stigma around in our society about addiction. Was really when I start going for rotations to the clinical departments that I start to see this dichotomy on how we were treating some disease compared to other disease.
yeah, for sure. And it is interesting to me in some sense that, you know, I have a physician friend he worked with a lot of addicts and stuff like that. And just what do I say? It's probably not quite the right word, but the lack of success in terms of patient outcomes, I think as a physician, right, you're trying to help them, but it's like, was there any sense ever of like frustration in terms of just how difficult of a problem it is dealing with an active addiction?
Right. I mean, that's for sure. It's still there, right? Because we still undertreat these medical conditions. We still have many challenges. There are challenges at the patient level. People are ashamed. People may not fully realize. So there is a sort of what we call pre-contemplation.
Yep.
People may not seek help. And I'm not blaming people. I'm just saying these are just things that happen. Many physicians, they just put their head under the sun. I'm not blaming my colleagues physicians. It's a consequence of lack of training during medical school, right? If you ask me, okay, Lorenzo, can you treat someone who doesn't text and drive? I would say, no, I was not trained as a physician. This is a medical condition.
Yeah.
Maybe it is, but as of now, you know, yeah, so I will feel uncomfortable, right? So the fact that we don't treat addiction, we don't talk about addiction during medical school or during residency, that makes many clinicians uncomfortable to have a discussion with patients. And rightly so, because you are uncomfortable as a doctor, as a clinician, to discuss a topic that you are not comfortable with.
Yeah.
But the lack of training, the lack of education in medical school also makes it harder for clinicians to identify the problem, at least in terms of referral. You know what I mean? That's also very important. And, you know, it's not that everybody can be trained or expert on anything by any means. But, for example, if you think about hypertension, just as an example, diabetes, any doctor will feel comfortable to say, your blood pressure is high or your glucose levels are not good. So talk with your primary care doctor, go to a specialist, whatever is a cardiologist or internal medicine doctor or endocrinologist, etc. So we don't have that. And last but not the least, there is a sort of a structural barrier that prevents people from having access to help/treatment. And that's just in the hospital, in the society structure, you know, the stigma around. I mean, I have seen too many hospitals where you go and there is a super nice department of oncology and cardiovascular disease with nice windows and plants and everything is clean and modern. And then addiction is often an addiction service in the basement in this very underdeveloped area of the hospital. often it's not in the hospital, it's in a different place.
Sure.
And now you're asking the patient to go from your, let's say, liver unit to the addiction unit in a different part of the city. People often don't have transportation. They don't have the money.
Nor are
to
they
afford-
well,
Yeah,
right? You know.
Exactly. So these are also structural barriers that they prevent. And the consequence are that, we undertreated these people. To give you some rough numbers, usually in the States, 85% of people with diabetes receive a medication for diabetes. The number of people who receive a treatment for alcohol use disorder, actually let me rephrase, the number of people with alcohol use disorder who receive an FDA approved treatment for alcohol use disorder is at 2%. This actually was a relatively recent JAMA psychiatry paper from my institute, actually from Dr. Wilson Compton, the deputy director, and Dr. Trish Powell, the deputy director of AAA.
We love JAMA.
Yeah.
Yeah.
So it's a big gap, right? And I intend to say help/treatment, because sometimes we physicians tend to see the solution to addiction to be primarily or merely treatment oriented from a medical standpoint, but it's much more complex.
One question I would have is, so people with substance use disorders, both in my anecdotal experience and just like reading through literature,
Sure.
almost everyone, probably above 80% have co-occurring, mental health disorders as currently defined. I think we're in like DSM-5, right? Like someone with a substance use disorder, like the most common probably are like depression and anxiety, right? And so they're using to cope with, things that they were struggling with probably before the addiction. Not in all cases, but for people, let's just use alcohol use disorder as an example, that are not receiving, quote unquote, an FDA approved medication for their alcohol use disorder, but they are being prescribed, say, like an SSRI or some type of anti-anxiety med. Do you think that's relevant in terms of, like, say, that statistic of being treated for alcoholism? Because I would think, just to like play the steel man, if someone's depression and anxiety improve as a result of being medicated for it, and then that improves their alcohol use disorder, I don't know if there's some type of like indirect, they are being treated for it in some sense. But I also know in this example, right, those medications don't tend to work very well if you're still drinking. So
Right. Yeah, this is some of the medications, like SSRIs, there is no strong evidence they work for addictions. But you're absolutely right that sometimes, and that's a limitation sometimes in early clinical research, we tend to study the unicorn, like those people who have, for example, anxiety, but they don't have substance use disorder, they don't have depression. Or we tend to study people with substance use disorder, but without anxiety, without depression, without mental health comorbidities. And then you try to bring something, whatever is the treatment, to the broader community. And sometimes you see much more variability. Well, why? Because the study was done in a way that the data were not really generalizable, because you really select a very well-defined subpopulation. So
I think like something that's really difficult with addiction too is when someone has an active addiction going, undoubtedly are depressed and, dealing with, in our current diagnostic buckets, something else other than just substance use disorder. But it's hard to distinguish in an active addiction what's even like their baseline, right? Like for example, someone in active addiction very much exhibit, qualities that would be consistent, say, with some type of cluster B personality disorder, but they don't actually have that. They're just in active addiction, right?
Right. No, you're absolutely right. I mean, in a sense, clinically speaking, sometimes there is this distinction between let's say, a primary diagnosis versus something secondary to substance use disorder. So you may have a patient with, let's say, alcohol use disorder and major depression disorder, and even if you are treating alcohol use disorder, major depression disorder is still there. But you may have people with alcohol use disorder and with depressive symptoms secondary to alcohol use disorder. And if you treat alcohol use disorder, the depressive symptoms go away. But sometimes in clinical practice, you really don't have the luxury to make this more DSM/didactic distinction. You have to treat everything you can to the best of your scientific and medical knowledge and in concert with the patient. That's critical to understand that nowadays everything we do has to be in concert with the patient. That's state of the art in clinical research, of course. We don't do anything without patient consent. But even clinical practice is very, very important and powerful to have a people/patients being part of the decision making. And this goes beyond a consent form. Hey, I'm doing endoscopy. This is the consent about the risk. That's obvious. We must inform people. But just the decision making is important because, doctors, clinicians, they're not these super powerful people who can read the crystal balls. They have to apply the best medical and scientific knowledge. And sometimes is not necessarily clear cut. So you have to make an estimate guess and make the patient part of this decision making. But one more thing I want to say, what you described before, which is absolutely spot on, about the complexity of a substance use disorder and mental health comorbidity, is exactly the reason why there is a lot of research ongoing to try to go beyond the specific classifications and actually go with what we'll call domains. One example is the RDoC domains that were developed by the National Institute of Mental Health.
The RDoC domains?
Right, yeah. And so the idea would be to really look at neuropsychiatric disorders as a whole and with clusters rather than the specific, somehow siloed categories.
Yeah, because currently we have these siloed categories, so to speak, right, in the DSM. But my hunch is that as we figure out the actual biology of these, the actual biology that results in features of mental health disorders, that our current diagnostic boundaries are, going to dissolve in some sense, right? And I also think one historical example that I think is really interesting and perhaps informative as to maybe some semblance of what could be achieved, right? If we figure out the biology of, say, mental health disorders, is I think it was the early 20th century, and there were people that would be put in psych wards and they would be labeled with a type of madness, so to speak, called, I think it was general paresis of the insane, GPI. Mm-hmm. I might have it wrong, and they would have all these crazy psychotic features, and once they passed away and they actually went to look at the brains, what was causing these features was a very simple thing, actually. Syphilis had gotten in the brain, right? And so things that look really complex symptom-wise, my hunch is that there might be a lot of not simple biology, but shared biology in a way. Right. So,
right. And there's so much we don't know because, the DSM is an amazing tool for clinicians, but I think it's important to see the DSM as an evolving tool. And this is, in fact, the case. Right now, we use the DSM-5, which means that we had 4 DSM before DSM-5. And even within DSM-5, then there is often what we call TR, text revised. And so the goal is that while the DSM is the state of the art in classifying mental health disorders, as we try to unfold more and more the biology, the underlying also gene by environment interactions, it would be very important to keep on developing new, better tools. Again, addictions are medical chronic disease. So what we are talking about is not fantasy, it's not very different compared to what has been happening in other fields, called cardiology, called oncology, where classifications, definitions, diagnostics have been keep on changing thanks to the development of new technologies, whether they're being clinical, imaging, molecular. For example, that's a big piece that we are still in its infancy to try to better understand the molecular causes and or consequences related to addiction. In oncology nowadays.
Do you mean that just generally too, within the body? Because most people, when they probably think about addiction, it's something's wrong in their brain, right? So the neurobiological underpinnings of addiction. But I think a lot of your work, right, has been focused on this, liver, gut, brain axis of sorts. So
absolutely. I would say, so we often refer to addiction as a brain disease. I myself, I have published on that concept as well.
Yep.
my boss, the NIDA director, Dr. Volkow, and Dr. George Kubin, anthropology director, they also have published in about the concept of addiction as a brain disease. And the former NIDA director, Dr. Alan Leshner, was among the first to actually publish in a highly provocative paper on science about addiction as a brain disease.
Yeah, I think I don't know exactly when it was published, maybe like the late 90s or 80s or something, but there was a paper, right, Addiction as a Brain Disease or something, that was very influential.
Right,
and
right.
then this kind of space in terms of viewing addiction as a brain disease, it remains a live kind of intellectual discussion. There are people that contest it, right? And so you were involved in the follow-up paper that was like over 20 years later in response to some of the criticisms, what I would say, of viewing addiction as a brain disease. And so you were one of the authors on like addiction. I don't remember what it was titled, but it was like not that long ago that it was published.
Right. It was a few years ago. The lead author was Dr. Marcus Hallig, who used to be here at NIH. Now he's in Linköping in Sweden. But the title is a direct quote from the science paper you were mentioned before from Dr. Alan Leshner about addiction as a brain disease, why it still matters, and need for reconciliation, something like that. I may not quote the title of this paper correctly. So and I was one of the co-authors, and I think we did a decent job in outline the reasons why it is important, and it's not an opinion, it's a science-driven data that show that addiction is a brain disease, but it's equally important to take into account the controversy in the field. It's also very important to take into account that when we talk about addiction as a brain disease, that does not negate by any means the critical role of the environment, the critical role of the social network, the critical role of all the social milieu that the people grow, etc. So the two things are absolutely compatible.
I always, when that type of argument is made, like, well, what about environment? What about like psychology? Blah blah blah. I hear those perspectives, but if those things are affecting biology, isn't it still like, what do I say? It's they're just different frames we're looking at, but it still results in some type of altered biology, right?
Absolutely.
I don't know if I'm articulating that well, but I'm
No, you are. You articulate very well. You're absolutely right. And in fact, I would say,
like I'll take an example here.
Yeah.
I think they've shown in probably rats, non-human primates, and even in humans, right, that changes in social hierarchy result in differences in availability of like dopamine D2 receptors or something like that, right? And so it's like this thing that seems social and environmental, and it is, still at the end of the day is resulting in some type of biological difference, right, in the person that ends up with an addiction.
Yeah, no, totally right. And also, flipping the coin for 1 second, you mentioned about social. One of our senior investigators here at NIDA and branch chief, Yavin Shaham, he has been pioneering some work actually with one of his former mentees, Marco Veniro, who is now faculty at UMB, on the role of social reward to actually somehow counteract the addictive seeking of rat models. So point being, to simplify what I just said, they show in multiple models how a rat will choose a social reward as opposite to the reward of an addictive drug.
Yeah.
And that's an animal model, but it does in a way point out to the importance of the social network in the context of addiction. I should also say that after the paper you mentioned before, which was on neuropsychopharmacology, there was a interesting point of view from a group actually from Italy, but I don't know them personally, and sadly I don't remember their names, but was published in Lancet Psychiatry. That point of view criticized pretty much every single point made in the paper that I'm a co-author, but I had to admit that it was really a joy to read. It was really well written. It's really well thought. I, as a scientist, disagree with many of their points, but it doesn't matter. we should disagree each other in order to move forward with better and better science.
I mean, yeah, like that's how good science happens,
Yeah,
right?
yeah.
Is you're able to have live discussion and people have
Exactly.
different views, but
Exactly.
it's not about anything
Yeah.
personal, right? It's
No,
just
it's not
about the
personal.
science. We want to
Yeah.
get to the truth.
And
right?
often the truth is somehow in between. Yeah, can we deny the biological components of addiction, including the brain component? No. But can we deny the importance of the non-biological, so to speak, environmental, social, etc.? No, just like we do not deny for diabetes, for obesity, for oncology. Cancer is obvious by now that it is also, at least in part, a byproduct of metabolic change, environmental change, etc. But you also have cancers which are directly driven by infectious disease, right? So medicine is complex, So one of my statements is, yeah, addiction is a brain disease, but also I would say, by the way, that also means it is a medical disease. And to be more precise, addiction is a medical chronic disease. It's not like a pneumonia, you get antibiotics and hopefully gets better. It's much more complex.
I also notice, I think I've heard this twice now, you mentioned addiction as a chronic disease, but you don't use the word a chronic relapsing disease. Is there anything, I guess, of interest that, makes you withhold that word?
Oh, no. To be honest, I'm trying to keep sometimes words or definitions simple. So, if you make a definition too wordy, then I want to make sure the message is simple to everybody. But definitely relapsing is part of the chronicity of addiction, right? And Macho, I'm glad you're asking, because when I get this question about the chronic nature of addiction and the chronic relapsing nature of addiction, I always make this analogy, which also goes back to our discussion about stigma. And that's the following. I ask the audience, if it's a student or a reporter, whoever, I say, would you be surprised if you are managing a patient with diabetes, and at some point this patient, he or she has been doing great in terms of glucose levels in their blood for months of years, and at some point you start to see uncontrolled glucose levels with a spike? No, you don't get shocked. You don't start blaming the patient. You sit down with the patient and say, okay, your diabetes is not as controlled as used to be. So let's see what's going on. Maybe you change your diet. Maybe you did gain weight. Maybe the medications you are taking are not effective any longer. Are you taking the medications? Maybe the medications are giving you side effects that prevent you from taking this medication. So there may be many. Maybe there is an inflammatory status in your body. You don't know, something, comorbidity that is actually now making your diabetes less controlled. Maybe you're taking new medications prescribed by another doctor that are interacting with the diabetes medication. So that would be the approach. Identical with addiction. So you have someone who is relapsing after a few years. That uncontrolled diabetes was a relapse in the diabetes field.
Yeah.
Addiction is the same. So then you sit down with the patient and say, okay, what happened? And in my experience as a clinician, the reasons may be all of the above. It could be, I lost my job, I divorced, or a very acute, very serious, stressful time in their life.
For sure. I mean, I think addiction is so characterized too by, we were talking about like how, social reward versus like addiction and rats. And, there's a saying that the opposite of addiction is connection, right? Not necessarily sobriety. There is sobriety, but then there's in my head, I don't know what your familiarity is with like 12-step work and kind of some of that type of thinking, but there's like abstinence from substance, and then there's like actual recovery in terms of, just because you're abstinent, I guess in my experience, if I'm not living my life in a certain way where I'm connected with others, like I am miserable, right? And so I'm trying to think how to connect this back to what we were talking about, but hopefully some of that makes sense.
Yeah, no, it totally makes sense. And in fact, I was using the example of stress because in particular, a significant stress for a major life change event or whatever kind.
Some type of disconnection.
Right.
Yeah.
But sometimes also the reason for relapse could be, I had many patients tell me, hey doc, I just want to try again, almost like an experiment. that's totally okay. I mean, people have the rights. People are adult, capable to make decisions. And back to your point about recovery, yeah, recovery is also a very complex term, so to speak, and the way how we define recovery is also subject to interpretation. At the end of the day, you want to improve a people's life.
Yep.
That's my mission as a physician and scientist. I see myself as a physician and a physician scientist, and that's the mission of NIH, to improve a people's life. And when we think about improving people's life, is people's lives in terms of quantity, life expectancy, but also quality. And at the end of the day, it depends how you envision at the individual level. Yeah. Because my quality of life, what I consider good quality of life, could be completely different compared to what you consider a good quality of life. So
yeah,
it's
people want different things, right?
People want different things. And we have plenty of data, for example, suggesting that given that if you have an alcohol use disorder, alcohol abstinence is definitely an important cornerstone, and even more if you have some medical consequence, liver, cardiovascular related, or whatever. But also there is a plethora now of data that show that reducing significantly alcohol drinking does lead to multiple health benefits on your liver, on your blood pressure, on your quality of life. And actually recently the FDA did, and I'm using little technical term, qualify the reduction in risky drinking levels as an acceptable outcome for medication clinical trials.
Yeah, and I in 12-step work, which I'm very familiar with, like I've worked the steps, I've been to a lot of meetings, right? I've had sponsors, et cetera, et cetera.
Yeah.
One thing I take issue with of sorts is it's great if someone can achieve full abstinence, right? And, live this like wonderfully connected life without substances anymore. But I definitely know, just like personally, like someone, they were an alcoholic for years and years and years and years. And one day they stopped and they're much better now, but they just like, they don't use THC to that extent, but they use it in some capacity, right? And so this idea that, when I say, one issue I take with 12-step work is I don't think it's very understanding of the idea of harm reduction. And I think for a lot of addicts, right, there's severity, and addiction is also a progressive disease in my view, right? There definitely gets a point where you can't really manage using any substance that makes you feel differently on demand, I guess. But there are people like that somehow improve their quality of life through some type of harm reduction, but it's not entire abstinence.
Right. Yeah, and it goes back to your point that we're all different to each other. So some people want abstinence. Some people need abstinence based on their consequences.
I need abstinence for sure.
It depends. Some people don't need necessarily abstinence. Some people don't want abstinence. Yeah. So to me, the want and need goes hand in hand. I do think that for some people, 12 steps AAs are critically important and highly beneficial. A colleague of mine, actually, we published a review together with many other scientists in the field, John Kelly from Harvard. He has been done some of the most elegant work in showing the benefits of AAs and 12-step programs in the context of alcohol use disorder. Does that mean that the AAs work for everybody? No. But do they work for somebody? Yes.
Yeah, we won't stay here too long, but I think one thing that is really positive about 12-step work, if you earnestly engage with it, is it helps you get honest with yourself, right? And to get square with the world in terms of like, these are these things I'm carrying around, and like, what do I need to do to be free of these things that bother me, right? From my past. And
with the risk of stating the obvious, I would say no one size fits all, right? So just like in and sorry if I'm redundant in always going back to this analogy with diabetes or oncology or hypertension, we know from that areas of medicine that you have different treatments, and these treatments work for some people but not others.
I think, John Kelly, I didn't reach out to him, but there is a guy in Minnesota he was collaborating with whose treatment center I went to that I got set up. They were like, Mitchell, reach out to this guy because he's working with this guy at Harvard about like evaluating 12-step work. And so I'd kind of heard about this actually. Nothing shook out for me, but yeah.
A reason that actually, I'm sidetracking for 1 second. A few days ago, a colleague of mine sent me this link on NPR about this community in Italy. Because I'm from Italy, everybody was saying, have you heard about? But it was interesting. John Kelly was interviewed by NPR on that. It was actually a 30-minute piece of NPR on this community called San Patrignano, where actually people live there for years and they work there. And so it's a very interesting model.
And there's no substances, I imagine?
Right.
Yeah.
Except, and I remember actually, I remember as a kid hearing, it's very popular in Italy. In particular, the founder who now died, the founder was very controversial. Actually, he went also through some legal challenge, etc., for some of his approaches. Sure. So, but because of that, it was very popular. The news were talking about him all the time. I think there was a Netflix movie about him. But the idea would be, that it's basically a substance-free community where people sleep, work there, live there for years, etc. Except, which is fun, I found interesting, they are allowed to have a glass of wine once a month to celebrate everybody's birthday.
That's interesting.
And one of the
was not expecting.
Yeah. And one question was how, this is a millions of euros enterprise, and more than half is a self-maintained through all the activities they do. One of them being actually is producing wine. They have winery and they produce and sell wine.
This is very interesting. I'll definitely have to look this up.
Yeah, take a look. It's very interesting model. And I think, I don't think, well, I know as a fact.
I can't drink, but I'm just I'm trying to think, how would this work? But yeah.
I know as a fact that it's not a model that works for everybody, but I think it's a model that we could learn from, at least for some people who may benefit from that model.
Yeah. So then, you got some exposure to addiction. You saw the stigma in Italy. You came over to the U.S.
Right.
You came to Brown University. And you want to just tell a little bit, I guess, kind of how the story unfolds from there. And you had, already been very interested, say, like in the liver and kind of gut in relation to addiction.
Yeah. Actually, I will tell you one more story that I found on a personal level very fascinating. So my first ever trip to the States was actually the year before I moved to Brown to attend the American Alcohol Conference. It's called the RSA, which stands for Research Society on Alcohol. So my mentor, Giovanni Dolorato, the same guy I was saying before that was really inspiration for me to make this move from the liver to the addiction as a bigger picture way to treat the people and to do science, etc. So he comes to me and say, I'm going to Sydney for another conference with my wife. He had just married. So I cannot go to the United States and then to Sydney. I cannot really do 2 trips back to back. So you go to the States for RSA. I go to Sydney for ISBRA. That's the name of the conference. So you're going to present our data. And I'm freaking out, like, what? In English? So you're asking me to talk in English? I was completely freaking out. I say, of course, I say yes. Actually, I try to say no. I said, well, Giovanni, I don't have the passport. Oh, don't worry. My cousin works at the police station here. He can help to fast track your passport.
They weren't going to let you out of it. So out of the blue,
I found this, who is now one of my best friends, of course, and former mentor. And as I tell to my mentees nowadays, mentor once and mentor forever. So I found him, put on my pocket the passport and the tickets. And guess what was RSA that year in 2006? Was here in Baltimore. So the first time ever I came to the States was in Baltimore.
Wow.
At that time, I remember in 2006, walking around Baltimore just to see the city. I was alone. I didn't know anybody. I barely could speak some English words at the best.
You're like, why is everyone so into American football? No one else in the world cares about this, right?
Yeah, maybe. Who knows? I may have thought about. Although, well, parenthetically, I remember sitting in the bar of the hotel with all the Italian people coming to this conference and watching the World Cup, because it was 2006. And I think there was Italy, Australia. that we Italy won, I think, with the penalty from Totti. Now I'm sidetracking a lot.
That's okay.
But that actually I forgot about. But anyway,
We're just showing that we're like humans and not just like
we are. I remember there was a lot
like
of
fully human, not just science.
Yeah.
But yeah.
And I still remember some of my friends who are now good friends and colleagues. One is Roberto Ciccocciopo from Camerino in Italy, close to Bologna. So if anybody was telling me at that time, in 2006, was stopping me and say, hey, dude, guess what? In 20 years, you'll be working in this city as a U.S. citizen and working for the NIH. I think I was going to laugh and say, no, what are you talking about? So
Yeah.
life is so strange. But anyway, I went back to Rome from Baltimore, and I go straight to my mentor and said, that conference was amazing. I mean, I met all the giants that I was reading papers one after another. You know, and you name it, you know, Ray Anton, Bob Swift, Barbara Mason, Hank Kranzler, and the list that goes on and on and on and on.
It's like your personal Hall of Fame,
Oh
right?
my gosh, I read in their papers at that time. There was this NIH and a AAA funded big clinical trial called the Combine that had just been published. And I remember seeing the data almost in real time presented at the conference. So I say I want to go back, but not just for a week, but for 1 year to really learn more about, in particular, this approach that was not part of our research there in Rome of experimental medicine in human lab studies. Basically, small clinical studies that are really meant to be a bridge between preclinical work and larger and more resource-intense clinical trials.
Can we get like perhaps an approximate of like what do we mean by a small clinical study?
Right. We are talking based on the question scientifically you're asking. For our study, that could be as small as 10 people,
Sure.
as big as 30, 40 people.
Yeah, but not hundreds and thousands.
Right. Definitely no hundreds.
Yeah, I just want to get like a little sense of scale.
And the goal of the studies is a twofold. You also deep dive on some safety questions, which is critically important. And you also use some experimental procedures to try to understand if the drug, the medication, has a signal enough to say, okay, this is worth continuing.
For sure. And I imagine it's hard in humans, right, in some ways to figure out if a drug has a signal because people live such variable lives, right? There's like a lot, in biology in general, right, there's a certain amount of complexity that you just can't always control for, but humans even like more so in terms of what we do with our lives. And so getting a signal that like a drug is doing something, I imagine, you know, let's say a drug is like kind of helpful, right? That's going to be hard probably to see in 10 people. Maybe if you have 100,000 and you can get some like noise out of that data and actually get the signal. But yeah, I don't know where I'm going with all that.
No, you are totally right. Actually, this is a challenge we have. You know, you do an experimental medicine experiment in animal models, and these animals did grow together in the same environment since the get-go, and they're quite uniform, even genetically speaking, etc. Right? They're not identical, to be clear, but they're similar. But then you do the same, or similar, I should say, not same, but similar study in humans, and there is a lot of variability. So it's a tricky. Also, when I refer to this experimental medicine approach, we don't really have a one state-of-the-art behavioral outcome that we know for sure this is the predictor of efficacy in a larger clinical trial.
Yeah.
We use many things. We use, for example, in my program, we have a bar, and we induce craving in real time using a bar environment cue activity.
In humans?
In humans. We also have a virtual reality to look at food seeking. We use fMRI to look at how the brain is reacting to cues and other tasks, but also to look just at the brain in its own, what we call resting state.
Yeah, and not to linger too long, but I guess just for like a general audience. So do you want to, I guess, just expound a little bit in terms of like what fMRI has enabled in terms of brain research? Like it's maybe the last, I don't know, 15, 20 years this really came to fruition?
Right. Yeah, so fMRI stands for functional magnetic resonance imaging. It's one of the techniques also used in clinical practice, sometimes to study the brain or any other part of the body, right? So sometimes people go to the doctors, they say, well, we need to look closer at your heart, for example.
Yeah.
So they may start with the EKG, but then they may do something called ultrasound, which could be an ultrasound of your belly, your abdomen, your heart, and that's actually using ultrasound. But sometimes you have to deep dive with something more precise.
Yep.
And typically, there are three approaches. One is a CT scan, one is an MRI, and one is a PET.
Yep.
So MRI is one of them, and to study the brain, the MRI is one of the best tools we have. And the reason why there is the F before MRI is because we don't study just the anatomy, the structure, but also we study the function of the brain, fMRI. And we study the brain at the resting state. So even if we sleep, even if let's say we look at white wall and nothing else, our brain is still active. Our brain is still very active, consume a lot of calories.
I mean, an environment literally shapes the brain, right?
Exactly. But then on top of that, we also exposure within this scanner. People lay down this big machine called MRI scanner, and we expose them with some specific equipment to cues. Could be alcohol, could be food. We also ask them to do some tasks. They had to make some decisions in real time about choosing something versus another. There are many examples, but there are, for example, tasks where they asked, think like, do you want the $2 now or you want the $20 in 1 hour? Yeah. That's technically called the delayed discounting. But the goal is actually to stimulate some specific areas of the brain and then understand how the brain is acting. Yeah. So to answer your question, fMRI together with PET has been instrumental in providing actually evidence in humans that the brain is actually quite involved in why some people develop addictive disorders.
Sure.
And the critical role of the brain in addictive disorders. Also, for example, there is actually now very robust literature showing how some parts of the brain are engaged, activated under specific circumstances. So, for example, classic example is that you have someone with alcohol use disorder in the scanner and someone without alcohol use disorder. And we expose both of them to alcohol cues, and you see in the scanner with fMRI that the some brain regions, such as, for example, regions related to reward processing, to pleasure, to liking, they get light up much more in people with alcohol use disorder compared to people without alcohol use disorder. So
sure.
basically, like the brain is working on a different speed when exposure to cues relevant to that specific addiction, in this case, alcohol.
Like the brain is doing things where being able to make the decision to say no is very different between those two people.
Correct.
Right?
Exactly.
And I can talk about that like lived experience wise, and it also kind of set up for where we're headed here. Like, so I have struggled with addiction kind of on and off since I was 17, right? I'm 29 now, and, doing good now, but I currently take a GLP-1. I take tirzepatide, right? Otherwise known, I think brand name is like Mounjaro and Zepbound. Until I got on this medication, if you were to so like my particular problem when I was younger, and like I said, it's progressive, it evolved into other things, but was like Adderall and Vyvanse, right? Like ADHD stimulant medications. And until I've been on a GLP-1, if you were to put a bottle of those in front of me, like the craving for it, like I can't think straight. It feels like an ant getting like their antennas crossed. Like I can go to another room, or I don't know, like try to do something else, but it's right there. Like, oh, that bottle, like you could go get some, right? And so, and I lived a life, for 16 years without having that experience, right? And then became very different, right, once I was introduced to that. And so I don't know. I thought maybe just sharing a little bit about like the live side of that, what that might be like. So
No, I mean, I was, first, I mean, thanks so much for sharing that. And number two, I mean, kudos to you for, managing and finding a way to manage the, life experience of addiction. And I think you are a great example that having addiction is one of the medical challenges we may have in our life, but there are solutions, right? And what is working for you, which is wonderful, may not work for the people.
Well, it's part of what's working for me. It's not a cure-all, right?
Yeah,
I think
exactly.
I want to be careful in that. We probably need more evidence before we can conclusively say that, say, a GLP-1 is like one size fits all, like good for everyone's addiction type of thing. But that's just been my anecdotal experience and understanding. But it's just a part of it, right?
Right. Yeah. You're absolutely right. I mean, it's helping you as part of all the things you are doing to manage this medical condition. And it's an example that, in fact, these are complex conditions for which you really have to have a long-term structure on how to manage.
Yeah, and I would say like the biggest thing I can point to, well, one, we talked about food noise versus substance noise. Like mine is much less substance noise, but the thing that's always been so hard with addiction when I've been sober is I'll be doing good, and then it can happen so quick, right? Where you run into a situation you weren't expecting, it's right there, you're really craving, you're like, oh, like maybe this time things will be fine, right? But that scenario, like, you know, I've run into situations in the 9.5 months I've been sober where something was right in front of me, right? And that like experience of craving, I have so much more room since I've been on a GLP-1 to like make a rational decision, is what I would say.
Wow, that's wonderful. So definitely to be very proud
like
of you.
It's turned the difficulty knob down. Like addiction's a beast to deal with, right? And
right.
Yeah, but I don't know. I thought, just sharing a little bit about
a
little
again,
experience
thanks so
there.
much for sharing. I think it's great what you have done.
I think I view it as my duty in a sense, right? There's this stigmatized thing that I have lived with, right? And I don't really worry about the stigma or anything, but just to show like, no, I'm a good person, right? I just like have this thing. So
plus, I mean, I would say you are young, of course. It's also, I think, you serve as a role model for people that there is a solution. There are things that may help, and it's great to think about overcoming these challenges sooner rather than later, right? Because acting sooner is always better.
For sure.
And this is always the case for any medical problem. You know, approaching diabetes sooner rather than later is key. Approaching addiction sooner rather than later is key. And we know that the prevention or early detection, at least, are critical for life expectancy and for having a good quality of life. It goes back to our discussions about quantity, but also quality.
Yeah, for sure. Coming back to, like addiction research, and you're both on the, on the bench, so to speak, but then also like in the clinic. So I'm trying to think how to begin here. I want to kind of dive into this GLP-1 topic, right? Sure. It's only of recently become very relevant in terms of like everyone kind of knowing about it, right? But the history of it, my understanding, I guess, do you want to lay out a little bit, what do I say, like the incretins and like how when you eat, your body produces, say, GLP-1 and GIP, and then like, I don't know, like in laying out the history of kind of how we started getting interested in GLP-1s for anything.
Right. Yeah. So it's a very interesting story, as many stories in medicine, right?
It involves lizards.
Exactly. So what we know now as a well-known knowledge in medicine is, and I will keep this very simple, just for now. So when we eat, our gut will censor that we are introducing nutrients to our body. And as a consequence, one of the key hormones that our gut will release is this hormone called the glucagon-like peptide 1, GLP-1. The goal of producing GLP-1 is because as we are introducing nutrients in our body, now the body wants to make sure that these nutrients and so eventually this energy goes within our cells. So we eat food, the glucose levels will go up naturally, but then we want to make sure that the glucose goes inside the cells, and we keep the glucose at steady and normal levels in the blood. Because in fact, if that doesn't happen, glucose may lead to toxicity in our cells.
Yeah, like a healthy person, their glucose is very regulated.
Exactly.
Right? Yeah.
So we eat food, and that will be censored by the gut, and will release a GLP-1. And GLP-1 will basically signal to the pancreas and basically tell the pancreas, okay, we have more glucose here, more nutrients, so can you release more insulin in order to reduce glucose levels and make sure that the glucose, and it's much more complex, but I'm simplifying to say that as a consequence, insulin will be released and that will keep our glucose levels under control and everything else related to the function of GLP-1 and insulin. And that is, in essence, the basis why these GLP-1 medications are effective to treat diabetes, because they boost our own GLP-1 system by keeping glucose levels lower in people with diabetes, precisely diabetes type 2. But on top of that, science has been also showing that there's also an area in the brain, or kind in the brain, it's called the NTS, the nucleus tractus solitarius, which is a brain region, and is a sort of a hub connecting the peripheral nervous system with the actual brain inside the skull. And that area does produce a GLP-1. So GLP-1 doesn't come just from the gut.
And this was a surprise, right?
There was a surprise. Usually many incretins are believed to be only peripherally,
like in the gut.
Produced.
Right. Yeah.
And not acting into the brain, because they cannot cross the blood-brain barrier. But GLP-1 is also produced in the NTS, this brain region.
Which is, when I was reading about this, I was like, that's shocking. Like the brain produces GLP-1 and it also has receptors for it, right?
Yeah.
And,
but to kind of sidetrack for 1 second, it's also interesting that we know for a long time that serotonin, we often think about, serotonin, depression, the brain. But the main source of serotonin in our body is the gut.
Yeah.
It's not the brain. But it was also clear over and over in science that the GLP-1 also plays a role in controlling appetite. So it does reduce appetite. It does reduce the food seeking. And whether this is the gut-driven GLP-1 going to the brain, or the brain produces GLP-1 acting to the brain, or the GLP-1 acting what we call the vagus nerve, and so indirectly signaling to the brain, and it could be a combo of all three of these potential hypotheses, the net outcome, the bottom line, is that GLP-1 will curb that desire to eat more food. So in a sense, if you think the peripheral function and the central function, they go hand in hand. So you are eating food, and so GLP-1 is taking care of, okay, number one, let's make sure glucose is under control. Number two, let's make sure that we stop introducing more food. And this second function was the basis how and why GLP-1s were started and eventually developed and approved for weight loss.
And it was, I think it was like in the 80s, right? So like classic high school biology, it's what, DNA to RNA to protein.
Right.
And I think it was like in the 80s, someone discovered this GLP-1 gene, right? And might have learned a little bit about it, and they were like, wow, that's interesting, but it didn't really make a lot of headway. And then I think like in the 90s, it like took some time. I think it was actually someone at the NIH. They were like, there's this lizard over in Arizona, and it only eats like once every 6 months.
Exactly.
Maybe we should take a look at what's going on there.
Yeah.
And so they did that, right? And then this is how, we started getting actually towards, medicative GLP-1s for humans.
Right. So if you think about, we basically what we have observed in the past years is a complete revolution in medicine, in how we treat diabetes and obesity, and how this is now expanding to potentially many other indications. Some of them being already reality now, liver, sleep problems, etc. And if you think that everything started by making observation about lizard, it's kind of
it's like very pure research, right?
Oh, exactly. But no, that observation from the lizard, the technical name is Gila monster, was instrumental because, as you point out, Gila monster only eats 2-3 times a year, right? Very infrequently. And why? On the other side, the other challenge was that while the biological and physiology work on GLP-1 was very intriguing, GLP-1, as many of these incretins, has a very short half-life.
Yeah.
So
like natural GLP-1,
natural,
right?
the one we have in our body that all of us have.
It's
right?
on the order of maybe like 90 seconds, 2 minutes. Probably depends a little bit.
Couple of minutes, yeah.
Yeah.
And so it turned out that the GLP-1 in the Gila monster, which is extending 4, has a much longer half-life. and that allows this, cute animal to drink less. So,
Monsters, yeah.
Right. So then the field say, well, maybe we can resemble that Gila monster GLP-1 to develop a treatment. And that's why over time, starting with exenatide and then liraglutide and then semaglutide, scientists and pharmaceutical companies have been keep on tweaking these peptides in a way to make them basically more potent.
Last longer, like the Gila.
But last longer. And one of the reasons why they last longer is because they are resistant to the degradation. So it turns out we have an enzyme in our body called the DPP4. And
oh, yes.
So this enzyme basically will degrade maybe it's a too technical word, but basically destroy the peptide quickly. So the body wants to make sure that you don't have too much GLP-1 in the body if you don't need.
Because you're going to need to eat it. You're going to need more nutrients. Yeah.
Exactly. Because, eating is part of our survival as a species also and individually. So DPP4s make sure that, GLP-1 goes out, does its job, and then it's gone. In fact, there are actually a class of drugs approved for diabetes type 2, similar to GLP-1s, but not for obesity. They're called the DPP4 inhibitors. And they work by, rather than acting on the GLP-1 receptor, they act on the DPP4 enzyme. They block.
Just to pause real quick. So
yeah.
I just want to drive a couple points home. So GLP-1 in humans, right, makes people feel full, but it's like actual lifetime in the body is not very long. So then there was this lizard, and they looked at its version of GLP-1, and it lasted a really long time.
Yeah.
And so they were like, what if we could get, something that lasts longer in humans, because look at the effects in this lizard, and then, kind of going down that avenue. And
right.
I think the first GLP-1 medication, correct me if I'm wrong, was exenatide, and it was like maybe around 2005.
Right.
And then maybe like a decade later is when, I don't know when trials started for something like Ozempic and stuff, but we've kind of seen this progression of where we get GLP-1 like molecules, right, that can stick around for longer, and they're able to hit the same receptor, and
right,
work.
Right. Yeah, and there are people, like the scientist who won the 2024 Lasker Award for Clinical Research, who started work on GLP-1s decades ago, really in the 60s. In clinical practice, as you point out, exenatide has been already used since 2005, so for 20 plus years already. And somehow this was not well noted. There was not a lot of attention. It was another medication for diabetes. But with the development of these newer GLP-1s like liraglutide and semaglutide, the field has been really transformed for two reasons. They are much more manageable clinically because you don't need to take twice a day like the original exenatide, but also because its effect on appetite and weight loss, which are quite remarkable.
Yeah. No, I don't know. A very interesting space. I think I was just reading or listening to GLP-1s, I think are FDA approved for obesity and probably diabetes, right? But a lot of people have anecdotally, reported that it's affected their life in other ways, like maybe they stop smoking or they don't spend as much and such like that. And so now there's, all this investigation going on of, okay, what is it about this, what we thought was primarily a gut hormone that's adjusting behaviors in pretty drastic ways, right? And so companies, we already have some of them, but they're actually I think trying to develop ones that more hone in on the adjustment of behavior that has resulted from the GLP-1s already on the market.
Right.
Correct me if I'm wrong.
This is a perfect summary, and I would say, as a matter of fact, that thanks to the GLP-1 developments, right now, the specific to addiction, it's really an amazing, exciting time because everybody's talking about GLP-1 and addiction. The research on GLP-1 addiction keeps on growing exponentially. And to me personally, above and beyond the GLP-1s, it's great that the people are talking about addiction. And so that is becoming more and more an important topic for discussion, not just in the academic towers, so to speak, but in the public discussions and comments with reporters, etc.
One thing I'm also curious about is I imagine you learned about GLP-1 when you were like internal medicine and kind of in the gut and stuff like that. But where does GLP-1 come into your story, I guess, addiction-wise?
Right. Yeah, so...
Oh, also,
Yeah.
as we go like kind of through that, I'm curious about, your maybe internal perspective of like this thing that you probably have been working on for a long, long time that no one knew nothing really about, right, has become very public and mainstream.
Right. Well, maybe I can start with the leather. So, by telling you that this is why I'm personally super excited, because in a way, regardless of what the final big picture outcome will be, I'm very excited that some of our work, I'm not taking full credits, but my team has been definitely contributing early on this work, that some of our work has been pushing the envelope to now something that is much bigger than ourselves. And I'll explain more as I walk you through how we end up where we are. So, and it kind of goes back to a little of my personal journey, because now I'm in Providence, Rhode Island. I came here in the States. That's after Baltimore. That's the year after, right? So now I get my visa, my appointment with Brown University. I come here as a visiting scholar. And after 3 years, I was a research fellow in psychiatry. I stayed as a junior faculty, assistant professor and PI. And I was very lucky to receive a funding from NIH, also from some foundations. So at this point, basically, I was almost done with my PhD. At this point, I'm thinking about myself as an addiction physician scientist. And at that time, I had started to become more and more interested on hormones in the context of alcohol use disorder. And one idea that I had early on was the idea that this stomach hormone called the ghrelin may be important in addictive disorders. And there was a scientist in Gothenburg who is now a very good friend of mine, Elizabeth Yellowhawk, who actually did some of the early work in animal models, working on this stomach hormone called the ghrelin, which is the hunger hormone.
I saw that you've done some research on ghrelin.
Right.
I don't know much about that, and I don't
Right.
think people typically ask you much about it.
Yeah.
But
It was more popular at some point, but now the GLP-1 story has been taken over. But that ghrelin story was, for me, a turning point once again. And as I became a junior PI with my own lab and trainees and operations, to really switch or focus my research interest in this specific question. That is, addiction is a chronic, relapsing medical disease, and it's a brain disease. But the brain does not work in isolation. The brain is part of the body. And it was very clear from neurology, from obesity, and from many other fields that these body-brain connections are critical. So we basically brought to the field, and not just me, but we were some of the first ones, and definitely the clinical side with patient studies, to basically push the envelope to say, let's see whether by studying these body-brain connections, such as gut-brain connections, we can better understand this brain disease called addiction and develop new treatments. So based on that, we start working on multiple neuroendocrine pathways, which are related to this body-brain communication. Again, based on the simple idea that the brain is not a silo. The brain works in continuous bidirectional crosstalk with the body.
my favorite example of this is there's been like pretty good evidence, right, that like your teeth brushing habits and oral health very much impacts like mental health and stuff like that.
Yeah. Absolutely. Also, sometimes I tell to some students, think about even expressions we use in daily life. We say, oh, gut feeling, go with your gut. I think each of us has experienced that feeling of this sort of a pain in your stomach, almost like a knife in your stomach, whenever something goes wrong, whatever is your partner upsetting you or whatever else. Everybody feels this tachycardia whenever we have some anxiety, we're anxious for whatever. So we have a daily examples of how the brain and the body crosstalk all the time. So we start working, and we're still working on multiple of these hormones that the crosstalk between the body and the brain. One is a hormone related to blood pressure and the heart. It's called aldosterone. and we are doing work on a drug related to aldosterone. The drug is called the spironolactone. One example, we had done some work with hormones like leptin and insulin. But primarily, since I was at Brown and then here at the NIH, I moved here in 2012, we have been focused on two hormones, the stomach hormone ghrelin and the gut hormone GLP-1. Our first paper in GLP-1 was in 2015, so 11 years ago. And before us, actually Elizabeth Yellowhag in Gothenburg, in 2013, she published the first preclinical paper in rats on GLP-1 and alcohol seeking. And then she told me, Lorenzo, I have a postdoc who wants to come to the States for 1 year. Can you host her? Say, yeah. And actually, I said, let's do something together as a collaborative United States-Swedish project. And one idea was to actually look at the human data from multiple sources and try to see if there was a connection between our own GLP-1 system and the genes of the GLP-1 receptor and alcohol use disorder.
Like saying that, so when we think of like hormone and receptor, it's kind of like lock and key, I guess,
Correct.
analogy, but that they're and the people that were suffering from alcohol addiction or probably other types of substance use disorders, that maybe there was a difference in the shapes of those like locks and keys. I think you said the lock component. But
Exactly. Very nicely done. In fact, exactly that's what we found. We found some consistent association findings, so we could not claim causality, but there was consistency that some of the different shapes of the lock, so technically speaking, genetic variants on the GLP-1 receptor, which typically make the receptor working less, those genetic variants, those shapes, increase the risk of developing alcohol use disorder. And that was our first paper in 2015, led by this Swedish postdoc, Petra Sushankova, who then went back to Sweden, and that's where she's with her family. So it was kind of 4 human studies, quite consistent in directing this idea that the different shape of the GLP-1 receptor gene was associated with the increased risk of alcohol use disorder.
that is fascinating. I didn't know this.
Yeah, in the same paper, actually, we also had a mouse experiment done by another colleague and friend of mine, Howard Baker in Charleston, MUSC, where basically they showed that a GLP-1 was a compound, never moved to be an actual medication, but was reducing alcohol drinking in a mouse model of alcohol dependence. So the Swedish data from Elizabeth Yellowhag and our own human data, we believe the first human data linking GLP-1 to alcohol.
That's crazy.
We're kind of the first evidence shaking trees. But to be very frank, we ourselves were working more on ghrelin and less on GLP-1. And that GLP-1 work was not really gaining a lot of traction until a few years ago when the literature started to explode, etc. With ghrelin, we have been facing some roadblocks because unfortunately there have not been ghrelin drugs in the market that we could repurpose. But with GLP-1 has been better, the stars aligned because as these medications made their way for diabetes and obesity.
Struck oil. Right?
Exactly.
Yeah.
We and many other my colleagues have been able to bring these medications back to basic science and back to the clinic to hopefully repurpose for addiction. So I think, before I retire, before I die, I think if I should summarize what I believe has been my small drop in the ocean contribution has been the idea of this gut-brain and body-brain connection contributing to addiction science. And number 2, that we have shown that in humans, in patients, so above and beyond addiction science, we can contribute to addiction medicine. But also our stories show how sometimes, some stories may be a mix of being in the right place, in the right moment, and just many actual things outside your control. We've been pushing our envelope on these lines of research, ghrelin, GLP-1, and many other pathways all around. GLP-1 now is the front runner, and now the picture is much bigger what we started in 2015. Now we have many academic PIs who work on GLP-1 clinically and preclinically. We have actually multi-site clinical trials funded by the extramural divisions of NIH, and we have pharmaceutical companies running clinical trials. So back to your original question, I know sometimes some reporters asking me, so do you feel like, hey guys, I told you many years ago, why you didn't listen to me? I don't feel that frustration. To me, actually, it's very rewarding to see that at least one of our stories is now leaving our town and flying to a much bigger city.
I feel like, yeah, I mean, it's like pretty rare, right? Going from what's going on at the bench in terms, and then that actually ending up in humans in any capacity, but let alone mass capacity. Like there's usually a huge delay if like any type of bench work ending up making a difference in a clinic, so to speak. And yeah, I guess I don't know if I'm summarizing great, but do you feel like ever like, man, I'm like lucky that this is what I was researching?
Oh, I'm beyond lucky. I think this is right now. I feel really like I think like I'm my 2.5 son at Walt Disney in Paris full time right now. Honestly, it's a super exciting time.
That's awesome.
Yeah, I still keep I keep my feet on the ground to be skeptical unless proven otherwise.
Yeah.
But there is no question that I'm very lucky. We started this research 11 years ago, and 11 years ago was one of the multiple hormones we were studying, and there was no indication or gut feeling, no pun intended, that this was going to become a big story, a much bigger than my own enterprise. But being lucky is critical. I hate to say, in my life, I've been always very lucky. If I can now make this a little more personalized.
Oh, yeah.
When I was in Italy, well, besides having amazing family support to me, but then when I was in Rome, I had amazing friends and colleagues, including my mentor. And when I moved to Brown, those were 5 fantastic years of my life. And I still am an adjunct professor there. I have many collaborators, people. One of my former mentees, Carolina Ascofa, she's now a star in the field and recently named Director of Innovation Clinical Trials. My 2 mentors, Bob Swift, is still an active professor psychiatrist, and George Kena now is a retired former professor in Charleston, enjoying his travels around. But they were super supportive. They really changed my life. But when there was this job opening at the NIH, I was almost ashamed to go to them and say, I would like to apply, because I felt like, they were going to say, hey, what's wrong with you? Why are you not happy here? I mean, like, we are supporting you. We're doing everything we can to make you productive and happy. Why you want to leave? But rather they say, shame on you if you don't apply. This job at NIH is a really unique position that Brown will never be able to match in terms of resources, etc. When I say resources, it's not just money in terms of funding, but it's really about the critical mass to go above and beyond what you can achieve as a single scientist. And there's no question, I've been very lucky coming here at the NIH. I have received a lot of support from leadership across both NIDA and AAA. But the beauty of the place where I work, which is the intramural component of the NIH, is that you can really do more risky, still safe, but risky scientific research to basically try to complement what is done in the academia, called Brown, Stanford, or wherever, but do actually develop and push for ideas that are more what we call high risk, high reward. So that's critical. It actually is a mandate of the intramural. And the second mandate
true,
of the
intellectual freedom,
exactly,
right?
Exactly. And the second mandate of the intramural is to be highly collaborative. So I think I told you at the beginning, my program as a principal investigator is really to address the questions such as, is GLP-1 effective in addiction?
And what do you believe? You don't have to say I know this, but what are your quick hitting thoughts in terms of that?
About this question?
Yeah.
Well, I would say A, still work in progress. So we don't know for sure. But if I should make a bet, I think that the answer is that they are going to work for some patients, but they're not going to work for every patient. It seems like a diplomatic statement, but I really believe as a scientist and as a clinician that that's the case. I do think there are people that will benefit from these medications, but if we believe that everybody's going to benefit from this medication, then we are wrong.
I think it's in the same vein too of what I was kind of describing for myself earlier. It's been an important part, right? But it's not everything.
It's not everything.
It's not a cure-all.
Yeah. And then maybe people for which it would not even be a part, it would just be
Yeah.
useless. And there would be people for which this medication would be super helpful. You know, as you know, we have heard multiple anecdotal evidence also reported in big mass media that, oh, I was on GLP-1 and I quit smoking, I quit drinking, etc. You know, being a physician, being trained as a physician, I think it's critical to listen to people. Some of the best ever discoveries in medicine came because scientists and clinicians did listen to their patients or research participants in clinical trials. Think about Viagra as an example. On the other side, as a scientist, it would be problematic if I was just listening to these anecdotal reports and make them as a state-of-the-art evidence. So then you had to bring back to the rigorous scientific approach to prove or disprove their role. Now, let's say that the trials will not show efficacy. Does that mean that the people were lying? Of course, people were not lying. People were telling the truth that they did have benefits from these medications. So then the question would be, who are these people? And actually, above and beyond addiction, if you look at the data from the obesity field, including the clinical trials that led to the approval of this medication for obesity.
A lot of the addiction research for GLP-1s so far, right, is with like people that have obesity or diabetes because they're on the medication. Right. And
exactly.
and
Particularly
then-
what we call pharmacoepidemiology, basically retrospective review of electronic health records, but analyzed with some sophisticated computational methods to match people and to reduce bias. But even within obesity, some of the data that led to the approval show clearly that not everybody lost weight. So there are people that do not respond to these medications. We don't know who these people are in terms of what are the characteristics.
Yeah, why?
Yeah, why? Do we have any biomarker that will tell you a priori you are going to respond, you are not going to respond?
Yeah.
And what else? I mean, in clinical trials, usually things are very well controlled, of course. But in clinical practice, yeah, you may have people responding to GLP-1s, people not responding to GLP-1s, but also everything else is important. Their environmental milieu, how much they're changing their diet, how much they're complying with the medication, what other potential stressors of external factors may influence their behavior, etc. So, as you pointed out before, when you move it from animal models to humans, that gap is huge, is a big leap.
Yep. We're almost at 2:00. We can cut out whatever here. I just want to be respectful of your time.
Sure.
Happy to go over time as well. I just don't know exactly your schedule. But one quick hitting question I want to ask you. It is related, but it's going to be a switch here. What are your thoughts? Like, how has AI impacted your work?
Yeah, well, it's impacted my work a lot, I think, like everybody else in the world, right? And we were talking before we started the podcast about my iPhones and the fact I don't see myself as the most tech-savvy person. I have colleagues and friends here at the intramural program NIDA who are way much more advanced. Like one of the PIs in my branch, Brenda Curtis, she is an AI guru, and she uses very sophisticated AI tools to do digital phenotyping and analyze, for example, how social media language may predict people's behavior. And this is just an example. But to answer your question, I think AI is definitely influencing my life for sure, like everybody else. I guess at two levels. On the one side, is a little stressful because you feel that you're not up to date on everything.
sure.
You feel you're always catching up, and
That's how I feel. Yeah.
Exactly. So I'm the clinical director of NIDA, and so I go to this biweekly meetings called the Scientific Director, Clinical Director meetings across all NIH. And we always have some updates from the National Library of Medicine about AI tools, and there is a ChatGPT for the NIH Intramural, and
like
then
a
there is
group shaming
Gemini,
session.
etc.
Yeah.
So I feel I keep on writing notes, go back and try to use, and I feel that the time I start to learn something, I'm already behind.
Yeah.
So that's one piece. But the second piece, which is less stressful and more exciting, there's no question that people say this is the future. No, this is the present. This is already
It's happening.
It's happening. So I would say that I'm super excited. Of course, I know there are many ethical dilemma,
Yeah.
people abusing, etc. Part of my answer is to be very frank. I cannot do everything. I cannot be an expert on everything. So I see myself in, I'm in a leadership position here at the NIH because I'm the clinical director of one of the institutes. And once you're in a leadership position, you learn that the part of your job is not to lead all the science. That's your job as a PI. But as someone, like in my case, clinical director of an institute, part of your job is to lead people. So I'm lucky enough to lead or co-lead with the scientific director of an area,
delegate and mentor
people
effectively,
who are
right?
the expert there.
Yeah.
So I did mention Dr. Brenda Curtis, she's an example, but we have many other scientists who do actually computational work in animal models. People, I can, for the audience, I can say a few names, like Jeff Schaubaum, Da Ting, Lei Shi. These are all basic scientists here where I work, whose computational models are highly sophisticated, and AI is a critical important. But then we also have clinical investigators. I mentioned Brenda Curtis, but we also have people like Thorsten Kant. We have people like Yong Yang, who actually use these highly computational models with human data.
Yeah.
So I'm not going to be an expert on AI. I'm not going to do AI research because it will not be a good service to taxpayers and to the community. But part of my job is to support these people who have the right training and skill set to actually put AI in a good place for science and for our patients, including people with addiction.
Yeah. Trying to think. Okay. Two more questions. We'll do them quick. So I've been having prior guests answer a question from the guest before them, and then they write a question for the next guest. And I
that's cool.
actually forgot to do this in my last podcast. So the last person who wrote a question is Mickey Marinelli, who
Which I know.
knows you, which I didn't know when I initially reached out. And so it's kind of just funny to me. I'm like, what a small world. But
Yeah.
I'll hand this over to you and open it up. It's a
Okay.
folded piece of paper in there, and I'll have a pen. Yep.
Okay.
And then underneath is your sheet, but we'll fill that out later.
Okay. Sounds good. So you don't want me to do now?
Oh, no, do it. Yeah, open up the paper.
So I open this one.
Yep. I don't know what the question is, but
Okay. You don't know either. Wow.
she might have told me, but I definitely don't remember, so.
Okay. So the question is, what tells you that you are alive? What signs tell you? Oh, I don't understand the last word. Oh.
I can give it a shot if you want.
Yeah. Mickey, if you're listening to us, I thought that
Jeez.
only doctors are allowed to write things that they cannot read.
What tells you that you are alive? What signs tell you that?
Oh, that. Okay.
Yeah.
Well, interesting question, Mickey.
I love that you guys know each other.
Yeah.
That's so funny.
So did she know that the question was going to be posed to me?
No,
Oh, she did.
no.
Okay. I was just
She
curious.
didn't tell me to reach out to you either or anything.
Okay,
I
okay.
found this out after the fact. So.
Okay. I would give it two answers, actually. I think one answer is very maybe silly and technical, but, forgive me for being this silly doctor who gives obvious answers. My heart is beating, so I'm alive. That's the first answer. But the second answer, because I know Mickey well, so of course she knows that as well, and I think the question is meant to be much more deeper and philosophical than just saying the heart is beating. Hello. I think what tells me that I'm alive is that every single day when I, get up, I have something to look forward to and someone to look up to. And these are the two things that make me not just a body alive, but as a human being with a soul who has something to do.
Yeah. Thank you.
Thank you.
And then
thank you, Mickey.
Yeah, one last question. So, as we were talking before we started, I'm so curious about people that end up in very unique societal positions or just doing very off the beaten path, so to speak, things with their life. And so, not in like an egotistical way at all or anything, but like, what do you think has really separated you to be able to end up in the position you're in compared to, like, there's a lot of smart people in the world. There's a lot of smart people who care about things, but like can't get the pieces put together effectively to really make a difference. So I guess I'm just curious, like, why you?
Yeah,
That's a hard question, but
it's a very hard question, and so I would say a couple of things. So first, I will quote myself about something I just said on the phone to someone who is an amazing physician scientist. Sorry, he's an amazing PA, physician assistant. But he has clearly the potential to become an amazing physician and physician scientist if he wants. And this person is right now debating about, okay, I'm a PA, physician assistant, but that's not enough. I want to do more. And one of the things he's considering is to go to medical school, which is very unusual for someone who is already a PA to go to medical school. And so this person is debating a lot about what should I do. And I told him, listen, at the end of the day, there is one thing that we have to be very thankful for. Life is not a placebo-controlled, fully factorial study. Sorry for using these boozy words. But the point I'm making is, and I was a little sarcastic using my own lingo as a physician scientist, that we make decisions in life, and once we make decisions, we have to move on. And there is no way in the world that we can go back and say, how about if I decide to do B rather than A? We are not allowed to do this in life. And thankfully, thanks God we can't, because it would be crazy. So the wonderful thing about life is that it's not controlled. You cannot go back and change your decision. And sometimes, which is what I told also to this young guy and super smart friend of mine, was make a decision. You don't need to rush, but sometimes not making a decision is worse than
not making a decision is a decision, right?
Right, exactly. But it's worse than making a decision, even if it may end up being not the best decision. Which brings to the second question I want to give you about the second answer to the question you asked me. Sorry, the answer to this, the answer to your first question.
Yes, I make decisions.
Yeah. So, first of all, I really meant, I'm not trying to be sort of like fake humble. I really see myself as a drop in the ocean, but I also believe each drop in the ocean is important.
Significant, yeah.
It's a significant. So I think I do play a role in the society in general, in the scientific community, but I'm one of the many. I believe one strength I have is that I have made decisions. And I'm thankful that I cannot go back to see whether my decisions were right or not.
Like, you can make decisions and you can live with them.
Right, exactly. A few years ago, someone, actually, he's a dean in medical school, asked me, are you a risk taker? And I gave an answer, which was my honest answer, was, I think I am, but I think I'm pretty good in making a calculated risk. Yeah. And so far, I have not broke the banking account. Yeah. So I have shown that this calculated risk has been, in fact, effective. Then I had to say that if the day after, I would think, well, maybe I could have even given a different answer, which would be less diplomatic, which was like, hello, I left my country. I moved to this other country with no clue even about speaking English. I had to learn. And I convinced who is now my wife, to move here. So, yes, I am a risk taker. But the answer I gave was honest. I am a risk taker, but it's a calculated risk. But then the second component, which I kind of alluded before, because you see that I keep on mentioning names of a bunch of people. There was a movie actually called The Human Capital, which is, to me, this has been critical in my life. So being very lucky to be in the right place at the right time. And there's no question that I'm here because I've been very lucky to cross the path of people who have changed my life in a critical way. Started from my mentor in Italy, Giovanna Dorato, my mentors at Brown, Bob Swift, and George Kena.
We call it who luck.
Yeah.
right? Who are the people you cross paths with that you were just, just changed everything for you, right? And
Right.
I mean that rhetorically,
Yeah.
but yeah.
Yeah, and the list goes on and on. At some point here at the NIH, I belong to both NIDA and AAA. And Dr. Nora Volkow, Dr. George Kubi, the two directors, have been beyond supportive of my career. But also the scientific director of NIDA intramural program, Dr. Amy Newman. Actually, I was talking with her this morning before you and I started the podcast. And for the reasons I was telling her about how she has been instrumental, a game changer in my life. Because at some point I was considering to leave NIH and go back to the academia. And she did step in and was able to retain me, actually support me in a career pathway that without Amy, Dr. Newman, there's no way I could have pursued to hold the positions and the leadership roles I have now. So she was beyond instrumental. Finally, I would say work is not everything in life. There is also life outside of work.
You describe yourself as a music junkie on X. I think that's something I came across. So I don't know if anyone's ever asked you about that, but
actually, it's interesting you said that because I didn't remember that I even put that on my X account until last month. One of my collaborators and friends, Marisa Roberto from Scripps, invited me to give a virtual lecture at Scripps. And she said, "Oh, Lorenzo, but I'm not going to introduce you. It's going to be Eric Zorilla," which I know Eric as well. And first I felt like, well, why is Marisa not introducing me? And she said, "Oh, Eric does an amazing job." Okay, I know Eric well as a scientist. I don't know Eric super well personally. But I have to say, it was kind of amazing, the kind of introduction that he gave about me. In part, as somebody said, also, if you read Lorenzo X, he describes himself as a music junkie. What? So I had completely forgotten, and he kind of refreshed my mind. So it's actually interesting that you are the second person in a couple of months that is bringing that up. But you're right. I mean, my job is intrinsic to my life every day, 24 hours a day. I never stop working either with my brain or physically working on whether it's about writing a paper, mentoring someone, writing a protocol, supervising people, seeing a patient, whatever I need to do. But I've been also lucky that my wife, Noemi, she has been beyond the supportive in tolerating a risk taker like me to do all the things I have done. She's a brilliant physician scientist. She's actually way much smarter than me, but she's been also an amazing partner in crime in this journey.
That's beautiful. Yeah.
And I mentioned before, we have now a child, Leonardo, who is 2.5 years, almost 2.5. And yes, music is a critical part of my life. I mean, I listen to music all the time. In fact, Leonardo, my child, is almost like a victim of my music junkie modus operandi, because he literally starts listening to music and singing before being able to talk.
What kind of music are we talking about? I'm imagining divorced dad rock, but that's actually probably not right. So
actually, I think I define myself as a music junkie because I really listen every type of music. I do listen a lot of Italian music, like a rock pop. But also I love, for example, Black Eyed Peas, at least the old Black Eyed Peas about, Where's the Love or Boom Boom
Black
Pie.
Eyed Peas.
I love that sort of
It's fascinating.
It's fascinating. I love opera. My wife and I go to opera and I listen. I mean, the beauty of YouTube is just amazing. I listen to the Marriage of Figaro once a month while I'm working on YouTube. I love opera as well. I also love kind of the more punk folk music of different kinds. So it's hard for me to find the type of music that I don't like, actually, to be very honest. And it's really part of my life in a very intrinsic way, yeah, so I hope that answers your question.
Yeah, I mean, that's a pretty intense question, but yeah, I'm very curious about that type of thing. So,
Yeah.
Well, anyways, we'll wrap up, and I just want to say thank you so much for your candidness and your time, and this has been great. I'm so happy I came out here, truly, and we'll leave it at that. So unless if you want to share some final words about, I don't know, things you're up to or things you would want to share to just the general audience.
No, I would just say, I will, from my perspective, I will wrap up by actually thanking you. I mean, you flew here from Texas to Maryland, and to visit us and to give me the opportunity to be, a guest in your podcast. And thanks for everything you do, including speaking up about your own life experience and then reaching out to people with very different backgrounds. Like Mickey Marinelli and I have a very different background, and just allowing us to speak and to reach to your audience and express who we are as a human being, as a scientist, as a physicians in my cases, as people who are really trying to make this world better. But we can do this because also we hopefully can communicate what we do to the broader community. So people like you are instrumental to really help us to go outside this ivy tower, so to speak, and speak to the broader
humanize,
community. And humanize. So thank you so much.
Yeah, no, I mean, I've got friends, that are, what do I say, we've seen, particularly in America, I don't know about other countries so much, but such a decline in trust in our institutions, right? And you are an important person within a federal, I don't know what you want to say, institution or thing going on. And whenever people, I say, like, denigrate or, like, are so skeptical of it, I'm like, well, who are the people you're skeptical of? Because there's people in these institutions, right? So I think it's really important to actually be like, no, these are, they're not just like scientific robots with bad intents, right? Like they're people. They're trying to help. So
yeah. Well said. Thank you so much.
Yeah.
Thanks for visiting us today.
Yeah. All right.
Okay.
That's it.